Okay, so the first specimen is from a 92-year-old female. She had a tea-color urine for a couple weeks. So this is her urine specimen. So this is a cytospin preparation. Most of the cells that we see are benign intermediate cell from the urothelium. There's a little bit of inflammation, but looks okay. So in between these like intermediate cells, there were a couple enlarged cells. It's slightly enlarged than the nucleus of the intermediate cells. It shows higher NC ratio, and the shape of the nucleus is a little bit irregular. It's not very rounded. There is a little bit of hyperchromasia and a little bit of coarse chromatin pattern. But because it's the cytospin preparation, I think the fixation is not very is not optimized, so it's a little bit difficult to appreciate more like a severe nuclear feature. So the a typical cell is not so many. They were like scattering around the otherwise benign looking like a background. So they were only just very scattered, these kind of atypical cells. So it looks like high-grade UC. I'm debating, should we just call it right away, or should we call it suspicious, because this is a new patient. From the image study, she had a lesion in the renal pelvis, so it is from the upper tract. So there is a filling defect of the renal pelvis. So for the upper tract urothelial carcinoma, unlike bladder urothelial carcinoma, usually the tumor cell can be very scant, such as this. Only very scant, and sometimes the degeneration is more remarkable than the bladder cancer. So for the bladder cancer, usually there will be just tons of high-grade urothelial carcinoma cells, but because it seems to be from the upper tract, and it is her very first specimen in our hospital, so we call it suspicious for high-grade urothelial carcinoma because scan cellularity and the preparation is not very good. But I think it is highly likely a high-grade UC. So if we just call it high-grade UC, I see it's probably also okay. Yeah. So this is the typical case for the upper tract that haven't been proved, but for the upper tract UC, sometimes the voided urine can just see only very scant legionel cells. So the second specimen is from a patient who had a renal transplant. So in this type of specimen, usually we are looking for the clue for virus inclusion. So in this specimen, the cellularity is relatively low. And in the background, you can see there are a lot of oxalate crystal. Oh. Just want to show you. You see, yeah. In the television, it's easier to see. There's like beautiful oxalate crystal, right? So there's a lot of oxalate crystal in these type of specimens. Sometimes they would be stone or some type of stone atypia. So you need to distinguish between like a stone atypia versus it's a true virus inclusions, cells with virus inclusion. So this type of cell, we call it decoy cell because it looks very much like a high-grade UC cell. It has a very high NC ratio. And from lower power, you would think that the cell looks very hyperchromatic. But when you go to higher power, these are actually ground glass type chromatin pattern. The nucleus is packed with virus inclusion, which doesn't stand. So it pushes away all the chromatin material to the periphery of the nucleus. So there you will see a condensed ring of staining. So this is called polyoma virus inclusion, and this is called decoy cell. So this one is positive for decoy. So for this type, we would say negative or high-grade UC, but this presence of polyoma virus inclusion. And the patient may need to adjust his anti-immune drug because otherwise, if the infection get more severe, the graft may be failed. So this one is typical. Whenever we want to see we want to call a polyoma virus positive specimen, we need to confirm with the viable cells without any degeneration. So if you find it could be a degeneration, usually we would ask the clinician to repeat the specimen. So this one is also without degeneration. It's a very beautiful inclusion cells. Okay, so this is positive for viral inclusion. So we have a couple effusion specimen that had immunostain. So the first one is pleural effusion from these patients with history of renal collecting duct carcinoma, which is a high-grade renal cell carcinoma. So the specimen, it had a quite proteinaceous background, and there were scattered cells with enlarged nucleus and very prominent nucleoli. But most of these are like loosely cohesive or only single cell without forming a tight cluster. So this is this is either a very high-grade fully differentiated carcinoma or just like very reactive like cells, mesothelial cell or histiocyte. It looks like it's a positive cells because the nucleoli is very, very prominent, cherry red. So this is the cell block preparation. In this specimen, we see a little bit more of cells, atypical cells in cluster. So we do a Pak-Se stain, which is a lineage-specific marker for renal cell. So as you can see, these tight cluster of cells are positive. There were also quite some scattered single cells positive for Pak-Se, and the nucleus of these cells looks pretty big. So this is, I think this is positive for metastatic renal cell carcinoma. And there were other cluster in the background which stand negative, which more likely to be a mesothelial cell, which we also do a carotene stain. So for a carotene stain, indeed, there were also cells positive because there should be mesothelial cell in the background. But as you can see, the cell looks a bit smaller than the Pak-Se positive cells. And in the background, they are indeed very large cell with very strange looking nucleoli, which is negative for mesothelial marker. And these cannot be histiocyte because it's way too big. And so this is supposedly to be positive for Pak-Se that we just saw in the other staining. I also try to do a clouding for. Unfortunately, there are not so many positive staining cells, only like a very few. This one looks malignant, but this is negative. Only this one is malignant. There were only a few cells positive for clouding for, so this is not a very good marker for the high-grade renal cell carcinoma, I suppose. Yeah. So Pak-Se is good to highlight the cell that we see. And you always need to correlate the morphology because there were mixed population in the background. So the next specimen that we also see yesterday, which is a patient with primary squamous cell carcinoma of gingiva. It's an oral cancer. And this is his pleura effusion specimen. So for the specimen, as we discussed yesterday, I think these cells looks very much like high-grade fully differentiated adenocarcinoma because of very prominent nucleoli, vesicular chromatin pattern, eccentric arrangement, and with like these like a bubbly, foamy cytoplasm. So it doesn't look like squamous cells in any sense. However, in our experience, high-grade SCC, when you metastasize to the effusion, it can looks like high-grade adenocarcinoma. So because of this discrepancy in morphology and history, we do a P40 stain, which is a lineage-specific marker for squamous cell carcinoma. As you can see, these large atypical cells are all positive. So history is very important. So as we discussed earlier, the metastatic squamous cell carcinoma in the pleura effusion, it can present with a couple different morphology. We've seen cases with like a highly necrotic squamous debris, like a keratin debris, the other day. And we've seen cases forming tight cluster with like a flattened lying down cells at the periphery in a cell ball. This is the other pattern. And this would be the third pattern that looks very much like high-grade adenocarcinoma, but it's positive for P40. Yeah, I think we had a couple of these type of cases, and it would be good for a study. And it's an easy one because we already do all the stain. And I think in the literature, there are not so many discussion about the cytomorphology pattern for the high-grade squamous cell, for the squamous cell carcinoma. So the next, we are looking forward to see, which is the mesothelioma. So let's see the immunostain pattern of these specimens. So first of all, we need to confirm the cell origin of these cells are mesothelial cells. So we use creatinine. So as you can see, these tight cell balls are all positive for creatinine. In the background, the negative cells are likely histiocyte. So you see there are more mesothelial cells than the histiocyte in the background. And for the mesothelial cell, they are all forming these cell ball or in like a single cells. And it is very common to see binucleation, as it is shown here. So this is confirmed to be a mesothelial cell origin. This is Claudin 4 that we would confirm if it's an epithelial origin, particularly glandular cells, and which is all negative. The Claudin 4 is negative. So these two are highly specific. And then we move to the differentiation between benign reactive versus malignant mesothelioma marker. So we do 3 markers. So we have a positive result for the first marker, which is BAP1. So for the BAP1 staining, as you can see, all these mesothelial cells show loss of nuclear expression. The cell that stain is the histiocyte that we see earlier from the creatinine stain. So it is beautifully demonstrate this loss of BAP1 staining pattern. So we are very confident that it is a malignant mesothelioma, despite these very bland-looking low-grade morphology. The other 2 stain, we have less experience, but I just want to try. So this is MTAP. This is a surrogate marker for deletion of CDKN2A. So there is no loss of expression. So this tumor doesn't have deletion of, probably doesn't have deletion of CDKN2A. The third marker, they have very few experience, which is Merlin. This is a new IHC that we have in our lab. It is different. As you can see, it has membranous staining instead of nuclear staining. But most of the mesothelial cells are still positive for these membranous staining, which means that probably it doesn't have loss of NF2, like a truncating type mutation or deletion of NF2. So the cell is, this is a negative result. Yeah. But we will do 3 different stems because it is all not 100%. But we are lucky that the BAP1 is very beautiful, so we can call it malignant mesothelioma. So the next specimen is from an elder female who present in our hospital with massive ascites. So this is her ascites specimen. So in this specimen, we see mostly cell cluster, and we go to higher power. These are definitely high-grade adenocarcinoma cells, and with vesicular chromatin prominent nucleoli, abundant bubbly cytoplasm, forming a 3-dimensional cluster, and some mitosis over here. So most common scenario, this is a high-grade serous carcinoma, either from the ovary, fallopian tube, or present as a primary peritoneal cancer. So this is a very typical specimen that we commonly see in our practice. The next case, the patient is an elder male who is a heavy smoker, but in his admission note, it says smoking denied, but who turned out to be a heavy smoker. And he had a large mediastinal mass as well as the lymph node positive. So it seems to be a central mass lesion in the thoracic cavity. It turned out to be a small cell carcinoma, which already been proved by the biopsy. So this is the pleura effusion, and we see tons of these malignant cells with prominent hyperchromasia. I want to show you that sometimes in the small cell carcinoma, the cell, despite the name, the cell is ironically not small. It is very, very big. So this is a reactive lymphocyte. This is a reactive lymphocyte, right? And this is a gigantic cells. But even though it's very big, I think the most important diagnostic morphologic feature for the small cell carcinoma is the high NC ratio and the chromatin pattern. So this is a very typical salt and pepper chromatin pattern that you can see, which basically just like a coarse, between coarse and fine chromatin, just like intermediate chromatin, and they were like a very homogeneous and diffusely scattered throughout the entire nucleus. And in between, there are some like small white spaces that you can see. Occasionally, for the small cell carcinoma, if it's well fixed, you can see nucleus sometimes. The other feature for the squamous cell carcinoma that it is a highly proliferative tumor, so it is very common to see these chorioresis, like individual cell apoptosis, suggests that it is highly proliferative. So as you can see, this looks like a nucleus. If it is well fixed, sometimes you will see a nucleus. And it is also very common to see mitosis. So the other feature like molding, etc., in these specimens is not very well demonstrated because the cell is a little bit too big, right? So this is positive for small cell carcinoma. So let's move to the finite aspiration. So this is a FNA from a thyroid lesion. So on low power, you can see that this is hemorrhagic cystic background. So you see a lot of hemosiderin-laden macrophages. There are some multinucleated giant cells as well. And then you start to see some three-dimensional papillary fragment. So it is a true papillary fragment because you can see fibrovascular core inside the cell fragment. But whenever you see a papillary structure, you still need to go to higher power to check the nuclear feature, and don't jump to the conclusion of papillary thyroid carcinoma so fast. You need to go to higher power to check the nuclear feature. So sometimes if it's a very thick fragment, it's not very easy to appreciate the nuclear feature. And you need to go to the periphery, or you need to check with the other fragment which shows more flattened arrangement that easy to appreciate. So in this fragment, the nuclear feature looks very bland looking. It is mostly rounded with uniform regular honeycombing arrangement. So this is actually a papillary hyperplasia instead of the papillary carcinoma. Despite that, you see these very convincing papillary structure, as well as some giant cells in the background, which can also present in the papillary hyperplasia or goiter with cystic change. So you go to the other fragment, and you can easily appreciate that this is benign follicular cells. So this specimen, this is just goiter with papillary hyperplasia and hemorrhage and cystic change. And the cells all look very bland looking. So this is a trick that you can occasionally see for the specimen with papillary hyperplasia, and mistakenly think this is a papillary carcinoma, but it is not. So you need to go to higher power to check. So the next specimen is also from thyroid. So in this specimen, it is less cellular. You see a lot of background material. It looks like mixture of blood and maybe a little bit of colloid, but it is not very prominent colloid pattern that we would usually see. So in between this specimen, you can find small tight cluster of follicular cell scattered around. The cellularity again is low, but you go to higher power, these looks like microfollicular pattern. So this could be a follicular neoplasm because of this arrangement and because the a little bit bloody background without like a very prominent colloid. So the case was signed out as AUS with architecture atypia. I checked the sono. It looks like it's a highly vascular, well demarcated nodule. So it could be a follicular tumor. So I signed it out as AUS with architecture atypia. So we have some interesting pap smear today. The first specimen is from a 64-year-old female. So we have a couple dots here in this specimen. So our diagnostic, our thinking process for pap smear is usually first you go to check if there is any atypical or lesional cells. So in this case, the screener do a very good job. They highlight quite a couple atypical looking cells. And the next step, first you highlight a typical cell. The next step is that you need to decide if this is squamous cells or glandular cells. So you need to go to the basic cytomorphology. For the squamous cells, usually you will have hyperchromasia, coarse chromatin. The cytoplasm is usually dense, and the arrangement is different. It's usually at the edge is usually flattened. So if you see these cells, the nuclear pattern you see, it is vesicular. It is not coarse chromatin. And you see small nucleoli. It is forming a three-dimensional architecture and with a glandular type of arrangement. So it was initially interpreted as a high CO. It is not a high CO. It is a glandular cell. So this looks like a glandular lesion. So the first step is decide if it is a squamous lesion or it is a glandular lesion. So this is not squamous, this is glandular. And because it has a nucleus, so we are thinking this is more toward to a neoplasm, probably adenocarcinoma. So then you decide the next thing is that what is the risk of lesion. For the glandular lesion, we have 3 tiers. We have 4 tiers actually. It's more than the squamous because it's more difficult. So we have AGC, atypical glandular cell. We have AGC, favored neoplasm. We have AIS. We have adenocarcinoma. We have 4 different layers. So we need to decide which risk is this that we can call it. Okay, so this is the basic thinking process. And for the glandular lesion, you also need to make judgment, if possible, to check the origin of this lesion, which includes endocervix and cervical and endometrium, as well as extrauterine. So you need to make these differentiation. So for this lesion, you can actually see there are some tumor diastasis over here, right? So this is a necrotic pattern. So for the endocervical, like adenocarcinoma, there were AIS. We've seen AIS yesterday. The case is, if you are not familiar, just check the slide again. And if it's an endocervical adenocarcinoma, usually there's more mucin differentiation, and because it is a cervical lesion, so you have direct sampling. So usually you will have very well preserved, like a fresh tumor cells. So in this specimen, I think these cells are all very well preserved because the chromatin pattern, the cell is well fixed, and it is the cell is just like very fresh, and it's easily to say that it is adenocarcinoma. So it is. And the amount of the lesional cell is plenty. It's a lot of tumor cells over here. So it is very reasonable that we can think the lesion is present at the cervix and you have the direct sampling of the lesion. However, you didn't see a lot of mucin background, and you start to see there are these like endometrium type, like a very tight cluster, and with like a phagocytosis or choreresis. This looks like a tight cluster of endometrium, like a matrix, stroma cells. So in the background, you actually can see some endometrium background. So the most likely clinical scenario is that this is endometrial adenocarcinoma with cervical involvement. So just from the cytomorphology, we have this as our top differential diagnosis. So we would call this as adenocarcinoma, not a high CO. And we think it is likely from the endometrial cavity and with cervical involvement. So you have like a lot of tumor cells. They are all show well preserved without flank degeneration. So the patient also had the DNC, which is a Gatti. So please let me know what would be the result of the DNC today. Okay, so this is not squamous lesion. This is adenocarcinoma. And it is not a primary cervical adenocarcinoma. It looks like endometrial adeno with cervical involvement. So this is a 39-year-old female. And this is a pap smear for screening. There's a very interesting group of cells which was highlighted. So in the beginning, you see, okay, these are very big cells comparing to the superficial cells. These show very big nucleus. It's more than 5 times larger. And it seems to be have some coarse chromatin pattern. And then we need to decide if this is a squamous or if this is a glandular lesion. So I would say this is a very difficult one. So at the beginning, I was convinced that this is a squamous lesion because of these seems to be coarse hyperchromatic chromatin pattern, and the cytoplasm is actually forming like a polygonal shape. There is edges or something like that. But if you take a look of the adjacent cells, you start to see this is terminal bar, this is cilia, this is cilia, and this is cilia. And there are some cilia over here. So this is tubal metaplasia. This is not a precursor lesion. This is tubal metaplasia. So for the reactive glandular lesion, sometimes the nuclear change can be even like a more pleomorphic than the squamous, like a reactive type lesion. The clue for the glandular lesion, I would say this is very difficult. The case is very difficult. If you didn't see the cilia, you cannot make like a good judgment. And for the case, you will have some like a debate. Should we call the ascus? Should we call this ascus high? Should we call this like AGC or anything? So this is quite a difficult case. But for the reactive glandular lesion, that is very common to have multinucleation. So multinucleation is not only present in the high CO, but it can show, it's more frequently to show in a reactive endocervical like a glandular change. So along this smearing direction, you can actually see these are also a cluster of endocervical gland with reactive type atypia. So we have a larger cells over here, smaller cells over here, and we have a terminal bar over here and the cilia over here. This one as well, you see? So the spindle cell is actually a toe columnar cell. So this is a tall columnar cell. You see terminal bar over here. You see cilia over here. So these entire cluster are all reactive, like endocervical gland with tubal metaplasia. Again, you go to here, you can probably think, okay, this is a little bit pleomorphic, a little bit atypical, but these are all glandular cells, so it is okay. And here again, this is cilia. So you see, these are pleomorphism. These are 3 times more bigger than this one, but it is okay because it is a glandular cells, and you see the terminal bar. The terminal bar over here, the terminal bar over here with binucleation, and sometimes the multinucleation can look like this with 5 or 6 or 7 nuclears in the cytoplasm, and there is cilia over here. So this entire direct, like a smearing area over here, are all reactive endocervical glands, some with tubal metaplasia. And for the tubal metaplasia lesion, it is notorious that you can call these as AIS, as high CO, as something like that. Yeah. So for these 2 cells, I would just say these are all reactive endocervical cells, and we call these case benign, reactive. So this is a good case. In this year, because I was convinced that for the traditional conventional smear, it is not very easy to see tubal metaplasia, but this year we see, I think 3 or 4 cases, right? So it happens. It's more common than we see. So this is a good case. So everybody that's not like familiar with the morphology, you can check with the slides, okay? So this is for today.